Hello, and welcome to Building Blocks, a telementoring series that's a part of CDC's Project First Line. Project First Line is a national training collaborative for infection prevention and control. In the AMA's work with Project First Line, we've gotten feedback from healthcare professionals that there are significant IPC challenges in facilities outside the acute hospital setting, places like dialysis centers and ambulatory surgery centers. In answer to that feedback, we've developed this telementoring series, bringing together healthcare professionals from these settings with IPC experts from across the country. Today's session will focus on some IPC questions that can arise within pediatric units. Family practitioners, pediatricians, and those in pediatric specialties care for the smallest of infants up to those in college. In addition to helping the children, they are also tending to the needs of the parents, families, and caregivers of these young patients. Pediatric clinics see children for routine wellness appointments as well as for more urgent needs. In addition, children have years when they are not fully vaccinated against things like measles and varicella, so pediatricians need to be especially aware of the infection prevention guidelines for these infectious diseases. When we think about labor and delivery units, many different types of healthcare professionals, obstetricians, midwives, anesthesiologists, nurses, and many others, come together to care for the parents and the babies. When you add in other family members and friends, there can be a lot of people waiting to see that newborn. In the best of situations, getting everyone to follow infection prevention and control guidelines can be challenging. When you add in additional factors like multi-drug resistant organisms or respiratory viruses, it can become incredibly difficult. Before I introduce our guest today, I'd like to remind everyone that the opinions expressed in this session are those of the presenters only and do not necessarily reflect the official position of the American Medical Association, U.S. Department of Health and Human Services, the Centers for Disease Control and Prevention, or the presenters' affiliated institutions. I want to also mention our ground rules. First, this is an all-share, all-learn format. We welcome other thoughts and viewpoints as disagreements can lead to great discussion. However, judging is not appropriate, and we want all interactions here to remain respectful. For those of you joining in chat and asking questions, please introduce yourselves, highlight the state you work in, and note your role in the healthcare system. Nurse, therapist, physician, or other role. We want to tailor our answers to what's most helpful to you. And lastly, please do not put any PHI in the chat. Just keep the questions general. I'm Dr. Erica Kaufman-West, the Director of Infectious Diseases at the American Medical Association. I'm also the physician lead on AMA's Project First Line grant, and I also maintain a clinical practice in Indiana. Now, allow me to introduce our panelists. Our presenters today are Dr. Elizabeth Butler and Dr. Joseph McBride. Dr. Butler attended the University of Massachusetts Medical School. She completed her residency through Brown Hasbro Pediatric Residency, and she now works as a primary care pediatrician in Rhode Island. Dr. McBride is an adult and pediatric infectious disease physician and researcher at the University of Wisconsin-Madison School of Medicine and Public Health. Dr. McBride practices a wide range of infectious diseases, including general adult, pediatric infectious diseases, HIV medicine, transplant infectious disease, and tropical medicine. He is the medical director of Unity Point Meriter Infection Prevention and Antimicrobial Stewardship Programs in Madison, Wisconsin. His medical education and residency training was at Loyola University, Chicago, Strick School of Medicine, prior to his ID fellowships at the University of Wisconsin-Madison. Our subject matter experts are Dr. Michelle Dahl and Dr. Margaret Fitzpatrick. Dr. Dahl is the System Hospital Epidemiologist for VCU Health System and an Associate Professor of Medicine in the Division of Infectious Diseases at VCU School of Medicine. She is the Medical Co-Director of the Virginia Infection Prevention Training Center. Dr. Dahl holds a Master of Public Health degree from VCU and is a member of the Virginia Healthcare Associated Infections Advisory Group. Dr. Fitzpatrick is an Associate Professor of Medicine in the Division of Infectious Diseases at the University of Colorado School of Medicine and an infectious disease physician and researcher at the VA Eastern Colorado Healthcare System in Aurora, Colorado. Her research studies the epidemiology and prevention of multi-drug resistant organisms and healthcare-associated infections in high-risk patients. We have two very different cases today, and I think they will hit on some really great challenges. Dr. McBride, can you set up case one for us?
Sure, thanks for the opportunity. So case number one. In the winter of 2021, a woman presents to the hospital in labor with a preterm pregnancy. She has no other complaints, but it's the hospital's policy to do a COVID swab for all admissions. She tests positive, which puts her in isolation. The baby is born and requires NICU admission. The baby's father is not swabbed for COVID and has complete access to the newborn and the unit. The mother is isolated, unable to hold or breastfeed her infant. So some of the questions that we had when working through this is, how did the procedures change throughout the, COVID pandemic?
Yeah, as I say, thanks for setting that up. I think we all remember how scary and horrible those that first year of COVID was, as far as trying to design protocols, trying to figure out what was the risk benefit of some of the decisions that we were making. So talk us through sort of what the protocol was at your facility way back at that time, and then we can maybe delve into how that changed.
Wonderful. I mean, this is really a very challenging situation for us throughout the pandemic. And I think, like a lot in infection prevention, it really evolved as we learned more about COVID, and what it can do and what it can't do. Immediately, right in the spring of 2020, the American Academy of Pediatrics actually put out guidelines for infection prevention in the setting of COVID positive birthing parents and the newborns. And the recommendations in April of that year were really to have isolation, which was really dramatic. Slowly, as again, we had more familiarity, those types of really aggressive infection prevention were starting to dissipate. And then we got a little bit more comfortable with babies being around a positive birthing parent. And then it got to the point where, well, maybe if the birthing parent was going to be in the normal newborn nursery and we had isolation and they could stay in their own rooms, that we felt comfortable with that and maybe wouldn't have to separate the parent and the child. But then it went to this really kind of a bizarre situation where we were worried about the equity of a lot of our infection prevention strategies, in that, what if a patient had to go to the NICU? And so obviously this is a neonatal ICU and their children are more at risk for bad outcomes. And we would do all these admission swabs for the birthing parent, but other family members wouldn't have admission swabs. And certainly they would have the questions like, are you febrile or do you have symptoms? But of course, almost universally, a lot of these people would say no, because if they were to say yes, that would prompt testing and maybe isolation and exclusion from visiting their newborn. And meanwhile, the birthing parent, desperately is, interested in meeting the newborn and spending time with the newborn, was excluded. So we would have these situations where, dad would be walking around the unit, probably, clearly exposed to mom and maybe with a degree of symptoms, and yet the mother didn't have access. And that didn't feel right, and it doesn't seem right. And so we went through a lot of different permutations on how we could liberalize or kind of open up our NICU for these parents, but have it be in a safe manner. And that was a really big challenge for us. So throughout the pandemic, we really got a lot of feedback from families, some who were really supportive of really keeping things separate, and others who were very much not supportive of that. And it was a really tough balance for us to try to navigate this world. So ultimately, we're at the point now where we think we've created an imperfect, but a strategy that would allow the birthing parent and the newborn to spend more time together safely, to promote things like skin-to-skin contact and breastfeeding, and it to be in a more equitable manner. And it's so much is dependent on good communication between the staff and the families, and trust between both groups, and really having isolated rooms for the patient and the baby. I think one of the things that in our own institution we felt really comfortable about was that in the exception of really twins or triplets, most of these rooms are going to be single baby rooms, which allowed a lot more flexibility. And certainly a lot of hospitals, the neonatal ICU is kind of in that large cohort setting. And I think if we were dealing with that, a lot of our practices might have changed. Our thoughts on that might have changed.
So your NICU is individual rooms rather than that sort of large
Exactly
one room
right.
setting.
Yeah. And I think that really is, if you're going to open up into a neonatal ICU to have people with COVID or other respiratory viruses visiting, I think that really is a must-have.
Mm-hmm.
A lot of these larger institutions that might have, open spaces with babies right next to each other. I think the risks of transmission across of, parent newborn dyads is really quite high. And so I think that's a must-have if you're going to be allowing this type of visitation and contact.
So did even within your small sort of single rooms, did you still advocate for masking then of the parents? I mean, that still can allow for some skin to skin contact and breastfeeding and those kinds of things, but did you have any thoughts, or what were your thoughts or protocols for masking of the parents then when, or I guess any visitor visiting the newborn?
That's right. So we really, even more than advocating it, that was part of the policy, not only for our COVID positive patients, but also for anybody going into our neonatal ICU during respiratory viral month in our hospital now. So yes, as a part of our initial strategy to kind of open up the unit, the birthing parents would have to be wearing a well-fitting mask, which we defined as even a surgical mask that was well-fitting would be appropriate for source control. And then, for things like skin to skin contact, obviously, wearing a contact isolation gown is probably not particularly helpful. But, good hand hygiene before and after interventions, things like that were really advocated. And then another thing that we thought was really important is almost like an usher or communicating with the L&D area, labor and delivery area, or from the home up into that neonatal ICU with communication. So, all right, we're going to pick a time at, let's say, 2:30 today that the known COVID positive individual is going to come, and we would make sure that maybe if there's a back door to the unit, that they use that back door, that they're not milling about in the lounge, or they're going straight to the room, not going down to the cafeteria or elevator where there might be other people. And so depending on your own building's facilities, that may be possible or may not be possible based on the structure of the area.
No, that makes sense. Hospitals can be difficult to navigate. And so even a well-meaning person might get lost and find themselves sort of meandering down the wrong section of the unit or the floor. So having that person being able to take them directly to where they would like to go, almost like a transporter, I could see how that would be of great benefit.
Yeah. Another concern that we had too, especially were other healthcare workers. So if I have a known COVID positive individual that's coming into the unit and they're going to be in the room and I'm the healthcare provider or someone else working, my risks of transmission might increase. And so we would have communication at the time. So maybe other visits could be limited. So if there was a respiratory therapist or some other physical therapist at that time, it could be scheduled around those visits. So we wouldn't have one of those situations where 15 people are trying to get into the room at the same time. So that really requires, it's easy to say these things, but it's really hard to coordinate it. And so a big part of our plan was when we do identify a dyad that has this situation is we have to bring in the nursing supervisors to really try to coordinate what the day-to-day activities might be for these children that frequently are quite busy going around the hospital or having other interventions take place.
That makes a lot of sense. And those little guys can't wear a mask themselves, so it's really important that everybody else does. Dr. Dahl, I wanted to sort of bring this out to you. Labor and delivery, as we said, has a lot of people sort of going through, a lot of visitors coming in. As Dr. McBride said, other sort of therapists and other folks coming in as well. In respiratory season, or if there are other sort of infectious disease precautions that need to be taken, how can we handle those?
Well, I think the summary we just went through is pretty complete. I don't have too much to add, but I would say that for our respiratory viruses, it kind of depends on what's going on in the unit, whether we're talking about one isolated case on the unit. We do some different things when we're in an outbreak situation. Those are times when we may look to do more broad restrictions around visitation, for example. We know that the visitors have value. They have value for our adult patients. They have a value for our smallest patients, even more so. in general, we don't like to allow ill visitors. We ask for that symptom screening at the door. We ask that you refrain from visiting when you are ill. This would be the one of the exceptions where there's just so much value to that time critical period where as much as it's practical, you make those special allowances. And so we went through a similar progression at our facility during this time period. And we also had the luxury of those single rooms. And again, emphasizing the hand hygiene and the wearing the mask for the source control of the potentially infected visitor. The one thing we didn't discuss that we emphasize, because you would be surprised how often this doesn't, it's not intuitively there for our visitors, is that if you are coming in with a special exception to visit a newborn, for example, you don't then go to the cafeteria and you don't then go to see other patients who you may know who are in the hospital. So that has to be, we found that has to be explicit. And then also, we slowly, I think we are trying to align what we're doing with COVID-19 to what we do for these other respiratory viruses, like influenza, for example. I guess the one other piece we didn't necessarily touch on, but we get called with a lot is questions around the breastfeeding. And in general, even if mom is ill, in general, we're trying to maintain the breastfeeding. And so in the example of having a respiratory viral illness, again, the source control and the hand hygiene before doing the breastfeeding would be recommended. But then the belief is that the benefit there then outweighs the risk for the baby. Some of the very rare exceptions that you'll see quoted is if there's some kind of like skin lesion that we believe is, for example, group A strep, or there's some skin lesion that we believe is HSV at the area where on the breast where the baby will be feeding, then it's advised not to do that during that time period until that's healed.
Thanks. There's always so much to consider when you're talking about the risk benefit with different scenarios within labor and delivery. And I think it's really, we can't obviously go through them all, but I think looking at some of these cases can really highlight where those challenges come in and how important it is to have a good relationship with either your epidemiologist at your hospital, your infectious disease physician, your infection preventionist, just to talk through some of these things. And as you both have keenly pointed out, that the communication, whether it's with the visitors and the family or whether that's just between the professionals in the hospital setting, is so important to make sure that we're protecting these littlest and most vulnerable of our patients. Okay, I'd like to move on to case number 2. Dr. Butler, can you share your case with us?
Yes, thank you. This case is a sick visit at our primary care clinic. Prior to the visit, a parent called in to report that their toddler child has had 2 days of fever, nasal congestion, runny nose, and a rash. The parent reported that the rash was localized to the face, that the rash was mildly itchy. It did not seem to be tender or particularly bothersome to the child. The family has been using acetaminophen and ibuprofen as needed for fever control. The child is in daycare. They have no specific infectious exposures. They have no recent international travel. The child is otherwise healthy and is up to date with their immunizations.
Well, I think that this case, it's not uncommon in pediatric clinics, I'm told, to have somebody with a fever and a rash. And while in the adult world, it kind of sparks some panic, it's not uncommon for you to deal with. So how does your clinic handle these types of phone calls? If you're lucky enough to get that parent that calls in ahead of time to explain what's going on, what happens when that phone call comes in?
Yes, so sometimes the physician will receive a verbal report of the phone call if it seems like it is a high acuity situation, if there's some particular concern regarding infection control that the parent reports. We are almost always given some type of information prior to the visit in the clinic notes. So we'll usually have, fever, rash, or cough, a little bit of information prior.
And now now we've we've gone through COVID. So before you used to just sort of bring your child in, sit in the waiting room and wait for your turn. Did that protocol or how patients wait, has that changed in your clinic?
It has changed. We now offer a virtual waiting room wherein the patient and the family remain in their car in the parking lot until they are texted or called to come directly into the room, thus bypassing the waiting room. Some of our families have kind of preferred and come back into waiting in the general waiting room, but the vast majority wait in their cars now.
I can see that might help prevent some unnecessary exposures if we're able to keep those sick kiddos away from sort of that general waiting room population.
Absolutely. Yes.
And so let's say in this particular case, if the parent and child are waiting in the car, they get that phone call, hey, we're ready for you. Does that then sort of bring them, somebody's waiting at the clinic door and takes them straight back to the exam room then?
We usually tell them which room to come in, and then we have signage up, rooms 1 through X are this way. In a situation where we might have a particular concern surrounding infection control, we can have them come in through sort of a back door or use our back office. We typically do not have someone waiting for them unless there's a compelling reason.
I see. So what happens next in this case?
Sure. So this patient, came into the room. We brought them directly into a room. We kind of kept them out of the waiting room and put them in a closed room furthest away from everyone else and closed the door. And myself and the staff do have access to personal protective equipment. So we're able to use that prior, as indicated. For this patient, in terms of the review of systems, the patient had no vomiting, no diarrhea. The child did have diminished appetite, but a reported normal urinary output. And on exam, the child was well appearing. The child had reassuring vital signs. They did have rhinorrhea and they had a rash that was discrete pink papular lesions that was indeed localized to the face only. And some of the lesions had some honey crusting on them. So after the exam, I did some testing on the patient, and the parent and family had questions regarding contagion, symptom control, and what would be the appropriate time frame for return to community daycare, family events, etc.
Wow, what a great case. The testing that you did, what were sort of the things highest on your list when you heard sort of fever and rash, and then when you got to the examination portion?
Sure. So prior, I was, concerned for varicella, a somewhat lower concern for measles, and then on the differential would be, hand, foot, mouth enterovirus, any other viral illness, and also impetigo. And on exam, the rash was most consistent with impetigo. So after seeing the patient, I had less concern for the other noted illnesses. I did do a PCR for varicella during that visit. So just unmoved the swab and did a PCR.
Got it. I assume that came back negative.
It did.
Great. Okay, so I'd like to ask Dr. Fitzpatrick to give us some comments on this. So Dr. Butler had a great differential of going into this case. Can you just say if she had gone in and measles was high on the list, how might that infection control practice differ from a varicella or a group A strep?
Absolutely. One thing I really like about this case is it really demonstrates this idea that is applicable in infection prevention to all patient populations, peds and adults, and really all care settings of looking for sort of syndromic pattern recognition and using that to kind of inform some of your infection prevention decisions. So here, we're talking about a constellation of signs and symptoms that kind of form a clinical syndrome, and that really informs a more limited differential diagnosis for infections that may have similar routes of transmission, and therefore that could really help inform you whether you need other transmission-based precautions, sort of above and beyond the standard precautions that we take for everyone. So the syndrome here is, a child, a toddler-aged child with fever and a rash, right? And so that really kind of informs a more limited set of possible infections to think about. So certainly, if the child had, for instance, a history of not having received all of their routine vaccinations, or if the appearance of the rash or the description of the rash had been a little different, things like varicella or measles might be higher on your differential list. And certainly both varicella and measles do share some features in terms of being highly contagious and also potentially being contagious via the aerosol route. So certainly if measles were higher on your list based on the clinical case or the patient's history or vaccination status or something like that, all of the things that Dr. Butler already mentioned, like a virtual waiting room, making sure that the patient didn't spend time in a public area or a waiting room, getting them directly into a private room, are all critical. But of course, if there's access to an airborne isolation room, certainly measles benefits from airborne isolation as sort of an enhanced transmission-based precaution if possible. Varicella, if it is more involving sort of more than one dermatome or more disseminated involvement, would also certainly benefit from airborne isolation. Varicella in all forms, if you're really concerned about it or have a high suspicion, would also benefit from contact-based precautions. So again, having those PPE available in your clinic, having gowns and gloves easily available, having N95 masks or other respirators appropriate for airborne isolation available so that staff can sort of quickly access them if there is a patient determined to be high risk is really important. And then, assuming in many clinic settings, you may not have an airborne isolation room or a negative airflow room, doing exactly what Dr. Butler mentioned, getting a patient just into a private room and closing the door and minimizing the people going in and out of that room is kind of the second best scenario. And then finally, Erica, you mentioned group A strep, which certainly might have been a little bit higher of a concern for this patient, given she'd been vaccinated or she'd had a history of having immunizations on time, and the patient had some sort of classic impetigo appearing rash. So group A strep, certainly is also highly contagious, and transmission-based precautions, if you have a concern for group A strep, is a little bit dependent upon the site of infection and the extent of the infection. So skin and soft tissue infection with group A strep, if it's relatively discrete and limited, just contact precautions can be helpful. If it's more extensive, a very severe skin and soft tissue infection, an open draining wound or necrotizing type infection, we do often like to include droplet precaution in addition to the contact precaution. So again, potentially having just those surgical masks available with your gowns and gloves available for your staff to use if there's a high suspicion.
And Dr. Butler, question for you. Does your office, do you guys have access to PPE such as, N95s and sort of that higher suspicion, measles suspicion PPE?
We do have access to it.
That's great. I know for a while there, they were tough to come by, and I think more clinics have been vigilant about making sure they have that stocked up, not knowing when you might have need for them. And then last question, what advice did you give to the parent as far as returning to daycare for the child with impetigo?
Sure. Yes. Families typically have many questions surrounding return to daycare, return to school, family members being able to go back to work, parties, etc. So I gave the guidance that, we are going to send the swab, which I, have a suspicion will be negative. So please, keep the child home until they have been afebrile times 24 hours. And if the swab comes back prior to that, I will, call you, but I would still remain the same guidance that the child should remain at home until no fever times 24 hours.
Great. I know that's always the tough part about having sick children is it affects the sort of the whole family and who can do what. So this sort of brings us to what I think are the unsung heroes of the healthcare facilities, which are environmental service workers. How does your office, Dr. Butler, how do they handle cleaning after, if this were varicella, how would that differ perhaps than if this were group A strep? Who does the cleaning? And then are there sort of deep cleaning that occurs in the office?
Sure. So after each patient, the room is cleaned by the nursing staff, so in between patients. And at the end of the day, overnight, a cleaning staff comes in and cleans the entire office. We have had scenarios where we have been concerned about airborne transmission. So we'll place a sign up on the door to, please keep the door closed for the next 2 hours, and would alert, anyone who's coming in afterwards to clean, as well as leaving the sign up with the time.
That's, again, communication is so important when you have these, and especially if people in the office leave, letting the next group that comes in for cleaning know sort of what's happened and what they need to watch for is really important. Thank you for that great case, and thank you all for joining us for our building block session today. Infections in pediatric units have wide-reaching effects on the children and their families, but also on other patients and clinical staff and their risks of getting an infection. We hope that you've learned a little more about how to look at IPC in pediatric spaces, and we thank you all for all you do for your patients every day. And one last thank you to our audience for joining us on this journey. You've asked such great questions and helped us explore the different IPC challenges that different healthcare facilities have. If you've missed any of our other sessions, you can find them on the website. Be safe.